So our next topic of the day is long QT syndrome in children. It's my great pleasure to invite Dr. Jeffrey Winokur, who is Director of Pediatric Electrophysiology Program here at the University of Rochester. Welcome, Jeff. Please share your thoughts.
Thank you. Good morning, everyone. Apologize if I lose my voice in the middle. So I wanted to talk, in some ways, long QT in children is the same as in adults, and in some ways it's different. So I will touch on things that are in many of the other talks. But I wanted to talk today about diagnosis, risk stratification, treatment, and planning ahead, which we always like to do in pediatrics. So in terms of diagnosis, people come to us sometimes on account of symptoms and sometimes on account of family history. Those of you who are here have already reached a diagnosis of long QT syndrome, so I don't want to touch too much on. But I do think it's very important in terms of medical education and working to the future that the symptoms of long QT syndrome are recognized when they occur. The number of children who come to me having seen a primary care doctor or an emergency room physician or a neurologist because of fainting or seizure that was not recognized is still much too high. This was mentioned briefly earlier. ECG is only helpful to a point. There are many people who have long QT syndrome with a normal ECG. And so in a family where long QT syndrome is known to occur, always the best thing is to do genetic testing on the most affected person, see what we can find, prove that it's real, and then follow it through the family. In the family members, it is very important to come for evaluation. I have a lot of trouble getting buy-in. When I have diagnosed someone that I want the cousins and the aunts and uncles and nephews and nieces to come, because often they feel fine and people want to leave them alone. But there is an enormous difference between having long QT syndrome, having been evaluated and put on a treatment plan that's appropriate for the situation, and having long QT syndrome that is unknown. I think we sort of covered that already. For those of you who are motivated enough to be here today, I suspect many of you have relatives that are less attentive to their health. And it is really hard, given how complicated families usually are, to get those relatives to step it up. But it really is important. And even if it's the cousins that nobody ever talks to, please try. In terms of risk stratification, long QT syndrome is not one disease. It's not 3 diseases. It's not 15 whatever diseases. Every scenario is its own thing. Long QT1 from a certain mutation will be different than long QT1 from a different mutation. And it is very important that the treatment match the risk in the individual situation. This is a philosophy that I think the oncologists, the cancer doctors, have really mastered in the past decades. Right? It's very clear. If you have an early stage cancer that's caught, resected completely, that's a very different prognosis, a very different recommendation of no chemo or a little bit of chemo than some widespread cancer that has to be treated very aggressively. And I think we are just entering the era in cardiology of trying to use that philosophy. There are people who have long QT syndrome, but who have a very low predicted risk for a life-threatening event, and they may need no active treatment at all, just to be aware of the triggers, how to avoid medications. There are other people who are at extremely high risk and need multiple medications, plus a defibrillator, plus other kinds of surgery. The other thing that I want to mention is that the risk changes over time. And this is a thing that we run into mostly in children, because once you hit adulthood, adulthood is more similar. So I brought a few interesting patients to tell you about, just to keep it lively. This is one who found out by accident to have a borderline QT measurement on an ECG done for an unrelated reason. Never had symptoms, no family history. Got genetic testing, does indeed have long QT syndrome, and happens to have a particular mutation that they have tons of in a little bit of Sweden, where somebody many hundreds of years ago had it, and then all of their offspring for generations have it. And so we happen to know from the enormous pedigrees that are available in Scandinavia because of all of the church records that thank you. So this is the sort of pedigree that they can develop in Scandinavia because there are parish records of baptisms and funerals for centuries. And so they know from 100 people who've had this mutation that with no treatment at all, the mortality is about 1%. And so you can safely say to this family that he has low risk, perhaps he should have nothing at all, just avoidance of triggers, or perhaps he could have a beta blocker to make his risk go from 1% to less than 1%, and they can think about their priorities in life and choose what to do. Here's a second one. This is a family where the father was found by accident to have a prolonged QT interval, I think when he was getting insurance. Had never had symptoms, got genetic testing, had long QT2. The family was tested. He had a young daughter who was in preschool, had long QT2, had a very mild QT prolongation, was advised by the cardiologist who saw her at that time that she was low risk, put on a low dose of beta blocker, and told not to worry much about it. Some time goes by, she hits puberty. I think some of you will know that long QT2 is worse in women once they reach puberty. And she has an episode of fainting while she's excited. She comes for second opinion, and here she is with a QT of 630, which I think most of you know is unbelievably long. And in fact, while she is walking into the office, and then of course we bring her upstairs into the hospital, she is having on and off periods of torsade, the very bad arrhythmia that comes in long QT, where the heart rate is, 250, 300, 350 beats per minute, coming a few seconds at a time, going away, coming, going away. Needless to say, she is no longer low risk. She is now very high risk. And we put in place a very intensive treatment plan to bring her back to a safe place. Okay.
So she got meds and a defibrillator?
She got meds and a defibrillator, correct. And we brought that QT from 630 to about 520 with medication, and then she got a defibrillator with pacing capability because some situations, long QT2 especially, pacing can help. And so with pacing, we brought her down to about 480. And I now have happily told her she can go back to her normal life. She plays sports, she does what she wants to do. I feel quite good about her. To move on to treatment, at a minimum, everyone with long QT syndrome needs to know the triggers to avoid and to have a safety plan in place. For some people, the trigger is likely to be adrenaline, sports, emotion. In long QT2, loud noises are a common trigger. Long QT3 can be sleep, which is a problematic trigger to avoid. Everyone needs to know about the QT prolonging medications. This, I think, is coming later in the day also. The other thing I always tell people is to trust no one. There are many, many pediatricians, doctors at urgent care, who will say, oh yeah, that's fine. I never learned in med school that one is a problem. I will tell you, every month there are new medicines on the list. The smartphone app is really good. Put it on your phone, you can check yourself. Takes 10 seconds. Sometimes, by the way, you will need a medicine that is on the list, right? You have other situations, you have infection, you have mental health issue, you have whatever it is, and you will be faced with the problem of what to do. And you have to then speak with your electrophysiologist, right? If you have bad depression, of course you're going to have to take something. But in the family of antidepressants, some are much better, some are much worse. Let us tell you what to choose. Other triggers to be aware of, electrolyte disturbance, so abnormal blood work related most often to having a GI bug, to having nausea, vomiting, diarrhea, can take somebody who was a low-risk person and bring them temporarily into a high-risk state for a few days. So something to keep in mind, go to the ER, get IV fluids if you're really having trouble. And lately there's some talk about fever, although I don't know how much we do differently other than try to treat your fever if you have fever. In terms of safety plan in childhood, that means a safety plan for home and a safety plan for school. At home, it's generally worthwhile for people to have gone to the Red Cross and learned CPR. It is not difficult. You could probably go on YouTube and learn what you need to know in about 3 minutes. If you want to get properly certified, you certainly can. We sometimes will prescribe AEDs. Those are the portable defibrillators like you see at the shopping mall or the airport. They almost never will get used, but there's pretty low downside to having them. And if we can get insurance to cover, which is probably about 3/4 of the time, then we go ahead and do that. In terms of school, this takes a lot of work. Most of the time, school will either want to ignore the issue altogether and say, the kid seems fine, what are you stressed about? Or completely overreact and refuse to let the child do anything at all, no matter what you have advised for them. And the truth, of course, is bound to be in the middle, right? Most children with long QT syndrome, we will let do gym class and usually even organized sports with adult supervision, with a defibrillator available, with a plan in place, just like you would have a plan for a fire, a plan for a bomb threat, a plan for a tornado, of what you would do if this child faints. Who's going to do crowd control? Who's going to call 911? Who's going to get the defibrillator? Who's going to do CPR? That has to be organized. The American Heart Association has example plans that are available online. That's this address that I put here. So CERP is Cardiac Emergency Response Plan. And it's really not that big of a deal. Almost all school nurses have had children with seizures who are doing fine and then all of a sudden out of the blue need emergency care. And they have a sense of like what needs to be done, what med do you have on hand, what do you do when it happens, how do you call 911. They will not usually have run into long QT syndrome before, but you work it through together with the help of your cardiologist, and we usually can get to a pretty good place. Some school districts are more problematic than others, and we often find that you need to request a 504 plan. So 504 is the number of the federal law that says that public schools have to take care of children with medical problems. And it puts in writing whatever your plan is going to be. You know, if you have a peanut allergy, there's a plan that nobody at your lunch table gets peanuts. If you have long QT syndrome, there's a plan about gym class and a plan about sports and a plan about defibrillators. And you can then hold them to account that they haven't followed what they put in writing. And so the challenge is to get over the hump of having one put in place. Once you have it, it's a valuable tool that can be on your side to help you. Very common question for me about children with long QT syndrome is about sports. This, of course, is a time of potential risk, especially for long QT1. On the other hand, everyone would agree that sports are important. Sports are important for social and emotional development, peer relationships. A lifestyle of physical activity is important for preventing adult heart problems that, of course, are extremely common in this country. And so I try very hard not to pull people out of sports. The exception to that is when you do not have your treatment plan in place. So at the time of a new diagnosis, especially if it's a new diagnosis because of an episode, everything is on hold, right? You do not go back to sports until you have been evaluated, risk stratified, started on whatever medication needs to be started, reevaluated, and decide that you're now in a good place. Nothing we can do will make the risk zero. And so it is important that the whole family be in agreement about where the balance lies. Some families will want to push a little further than I might wish because it's important to them. Everybody in the family has been on the swim team for generations. That's what they want. I can't talk them into soccer. We make our best plan about how to keep swimming safe and go forwards. Other families, I might feel like soccer is a very reasonable and appropriate activity, but some parent is nervous. And I'm not going to force you to put your kid in soccer if that's past your comfort level. The other thing that I think is very important as a physician and as a parent is to pick your battles. If you tell your child no exercise of any kind, all that will happen is they exercise when you don't know. And that is the worst. I would much rather they be exercising at school with adult supervision, with a safety plan in place, than out in the next door neighbor's backyard when nobody is watching. And so I try to save my sway on the child or adolescent for these issues. If you want to run, can I convince you to do indoor track and not cross country? Right? There's a big difference, a pile of 14-year-olds out in the woods with no adult around, and something happens. Then something happens in the school gym or on the school track. Can I convince you to do a sport that's on dry land, that's not climbing and not swimming? To move on to medication, many people, probably most people with long QT syndrome, at least in childhood, will be recommended a trial of beta blocker. There is a fair amount of research now that not all beta blockers are the same. The two that we like the best are nadolol and propranolol. We use mostly nadolol, especially in children, because the pills are easy to work with. They come in a lot of different sizes. You can cut them in half. You can crush them. They're very easy. Propranolol is quite a good medicine as a cardiologist, but it can be a challenge for a family because the doses are funny sizes. They're capsules that you can't cut. There's no very small ones that you could use in a young child, other than the short-acting propranolol that has to be given 3 or 4 times a day, and of course we try to avoid. We do sometimes reluctantly use other beta blockers, metoprolol and atenolol, but understanding they do not work as well. Everyone hates beta blocker if you start them at a high dose all of a sudden. Our best success is when we start at a low dose and work up gradually. Even then, there are still sometimes significant issues. Can I hang on till the end? In terms of who should be treated with beta blocker at all, in adulthood it's a complicated question because you may have had decades of being asymptomatic by the time you're diagnosed, and that puts you in a different place than someone who comes in childhood and we don't know yet what the future holds. The high-risk patients, of course, we want to be treated. The low-risk patients, I personally am often in favor of trying a little bit of beta blocker because many kids tolerate it perfectly well. And then why not? Sometimes a low-risk patient, we try it, they don't like it, we decide we're going to sit tight and just avoid triggers. There are other options when nadolol or propranolol is not enough or not tolerated, including other medications and also including two kinds of invasive procedures. The denervation surgery that some people call sympathectomy. This is a minimally invasive procedure with a little scope between the ribs to interfere with the adrenaline being delivered to the heart. The other is implanted device. We very rarely do pacemaker alone nowadays, except perhaps in a very small child. Most of the time, if we're talking about a device, we're talking about a defibrillator or a pacemaker defibrillator combination. Those, of course, are very important tools when we need them, but they come with significant downside, and so we always try to find an alternative treatment plan if we can. In terms of planning for the future, especially if you have young children, to try to sway them towards the kind of sports that are easier to supervise. Right? If the kid is equally interested in swimming and basketball, let's go for basketball. When they start to think about career, some of the same issues. Are they going to be cleared for the career that they want? Is it going to be safe for them to do the career that they want? Right? If they want to be police, fire, military, pilot, that may be a big problem. If they want to do something where you're out in the wilderness with no one around, their boss may clear them, but you may worry about them a lot. So it's important to start thinking about that as they develop their interests. And finally, just to say, reproductive planning is not something to start talking about when you just got married and are thinking about having children. This is something we start talking about in adolescence because it comes up well before you think it will. Thank you.